Hello, I'm Carrie Sipp, Director of Nonprofit Partnerships for CHC, Creating Healthier Communities. And we're thrilled to have you here today for the third in our series of CHC University webinars. Today, Neuro-Nurturing, Advancing Powerful Strategies for Lifelong Health, the Black Birthing and Decade of the Child initiatives. We are about supporting our partnerships and creating healthier communities. CHC exists so that every person in every community has an opportunity to live their healthiest life. We've been at this for 70 years, increasing capacity and boosting fundraising and helping grow engagement for thousands of partners nationwide. This webinar is backed by popular demand. Conveners Bill Barberg and I got this gang together first, minus Demetrius in January, but then Demetrius came along with us in March, and we had just a tremendous show of support for the webinar when we did it in March. The interest was incredibly high on CHC's Black Birthing Initiative, and we received such positive feedback that we went to CHC leadership and said, let's do this webinar as part of the CHC University. It's May, Mental Health Month. It's Maternal Mental Health Month. So we got the team back together again for today. So I'm the convener moderator with CHC and also co-direct as a volunteer, pacesconnection.com. Demetrius Geiger. Beatrice Beebe is not with us today, but we're sharing wonderful videos of hers. Deb McNellis. We also have with us Dr. Diana Fishbein, Dr. Christina Bethel, my partner convener, Bill Barberg, and Joshua Lisbon Zawadi will not be with us today after all, but Bill will cover for Joshua. What we're doing today, we're sharing about the importance of this concept of neuro-nurturing. Nurturing the mother and the baby for optimal brain development, health, and well-being. This is so important for health across the lifespan. We're extending CHC's Black Birthing Initiative to be not just about surviving, but about thriving. We're going to learn more about what neuro-nurturing is exactly from Deb McNellis. And then Christina Bethel is going to help us learn how to operationalize neuro-nurturing and so much more into existing frameworks that can benefit the whole child, the doctor-patient relationship, and communities, and how you can play a role. Dr. Fishbein is going to share with us the Decade of the Child initiative and how you can be a part. And then Bill is going to share with us about engaging fathers and scaling this cross-sector, multi-pronged approach to improve our nation's health across the lifespan, one baby, one family, one community at a time. So you're going to hear a little bit more about what we're grounded in, which is the ACEs, Adverse Childhood Experiences Science. We know that when a person has more than 4 ACEs, the likelihood of physical and mental health challenges increase by 2 to 3 times in adulthood. We're going to learn about positive childhood experiences, protective factors, and neuroplasticity. And if at any time in this presentation you're concerned that you didn't neuro-nurture your child, or you're an adoptive or foster parent, and your child did not have a neuro-nurturing start, I'm here to tell you neuroplasticity is with us across the lifespan. We need to increase positive childhood and community experiences and incorporate neuro-nurturing everywhere all the time. It's so important right now because pregnant and newly delivered women need our help. 1 in 20 women is a victim of domestic violence in pregnancy. 1 in 7 suffer from postpartum. And that really affects their ability to bond with their babies. Giving support to mothers, providing that support leads to improved infant health. And that's good for everybody because we have better long-term outcomes in mother and child. So today we're going to talk about investing in programs that support mothers, infants, and new families. And that's going to translate into healthier communities. Look out, operations for collaboration are coming up. A bit more about CHC. We are here to help nonprofits. We're here to help you grow revenue and become more financially secure by helping you with your workplace giving. We're here to help you be even more equitable and better places to work, and to help you in supporting your hope for creating healthier communities. We support thousands of nonprofit partners, as you can see from some of the logos there. This CHC University event and our events are free to all current partners. All nonprofit employees, donors, and volunteers are invited to attend, and we'll be sending recordings to all webinar registrants. So again, a little bit more about CHC. We impact about 5,000 nonprofits. We work with about 650 corporate business partners to help run their workplace giving campaigns. We touch the lives of between 17 and 21 million people. We do a lot of work beyond that with multi-sector partnerships and programs. You're going to hear a lot more about one of those from Demetrius in just a minute, but we also help with events, with custom volunteer projects, comprehensive landscape assessments. We help expand capacity. We help with marketing, financial management, and grant making and going after grants. So that brings me to Demetrius Geiger. It is my pleasure to introduce Demetrius, a colleague who's the program manager at CHC. She's an MPH from the Morehouse School of Medicine and has run the CHC Black Birthing Initiative for almost 3 years. Demetrius, thank you. Take it away.
Thank you so much, Carrie, for the wonderful introduction. It's really an honor to be among all the presenters today. You all are so amazing, and also just the attendees in general. And so today I will be presenting on one of several of CHC's impact programs, the Black Birthing Initiative, and our notable impact that we've made thus far. And also we'll speak a little bit about how you can get involved. So we have to talk about the problem. So for the Black Birth Initiative, we do know that Black women continue to face higher risk for maternal mortality, morbidity, and also preterm birth rates. And so to improve maternal health outcomes, CHC developed the Black Birthing Initiative with support from Elevance Health Foundation. And so the BBI is a community-based intervention that's aimed at addressing disparities in preterm births among Black women and birthing people by addressing a couple of things. We want to reduce the effects of stress and unmet social determinant of health needs. And so the BBI is a multifaceted approach that leverages the expertise of the community, organizational leaders, doulas, and also other birth advocates to employ this program to improve the maternal health standards of care. And so with the BBI, we piloted the program in Atlanta, Georgia, Cleveland, Ohio, and Detroit, Michigan. So we'll get into the program model a bit. The BBI is a scalable program that serves a tailored tool to capture one unique lived experience of Black women so that we can identify the stressors that are correlated with preterm births. And then also the BBI serves as a framework that builds on community-based partnerships to address those social determinants of health, where there is a sweet spot for allocating resources effectively to ensure that folks' needs are comprehensively met. And so during the formative phase or the information gathering phase of the BBI, we actually spent about a week or so in each city so that we could be deeply, invested in understanding unique needs and also the experiences of Black birthing people in each community, because no Black community is a monolith. So we wanted to really deeply engage with those communities. And through these listening sessions and interviews that we conducted, we were able to gather those additional insights that really shaped the implementation guide and the framework for the BBI, so that we wanted to ensure that we're uplifting and incorporating the community voices because they are the center and the soul of all solutions. And so with this BBI program, the model is really centered around 6 core elements. You see them on the right screen here in the flower, figure, or graphic. And it's really linking these participants to doulas or birth advocates, depending on what the community names them as. It could be a community health worker that is connected with that client throughout their pregnancy journey. And so those 6 core elements will include screening, doing that intake, that deep dive to understand that client's needs and desires. We have that case management and referral resource navigation, prenatal education, advocacy, social and group programming, and of course, birth accompaniment. So you'll see here that achieving these positive outcomes, it does definitely take an integration of different elements. I do want to note before we go forward that the final analysis of the BBI is being conducted at this time. So I must show the appreciation for the doulas and also how we really incorporated doula engagement in this model. We were really intentional at CHC about ensuring that the nurturers were nurtured and also to incorporate equitable compensation and also a caseload that was manageable. Oftentimes doulas, CHWs, they're often overburdened and burnt out. So we thought that was a very key thing to implement in the BBI. We also offer professional development and mentorship opportunities to make sure that doula was upskilled to be able to support their clients. And then most importantly, this program was built by doulas. And you'll see a quote here at the bottom of my slide that really alludes to the deep commitment and the solidarity among doulas, that one doula was with a client for 72 hours while they labored. And so those doulas rotated in and out to make sure that key main doula was nourished. And so it really speaks to that unforeseen care, unseen care with doulas and birth workers in the maternal health space. And so here displayed are a few of our BBI notable achievements thus far. And ones that I would love to highlight with you all today is that 90% of BBI participants had full-time births, which is amazing compared to the 54% of the national average. Also, 365 birthing people were connected with doulas. About 95% of clients reported reduced anxiety through the program. And also, we were able to support 17 birth workers with a fair wage through the BBI. And then lastly, there's about an estimated $2 million healthcare cost savings due to the low preterm birth rate here. And so now that you've seen a bit about the BBI's impact, I would like to explore and discuss how we're scaling and expanding the program. So I've mentioned this before, but BBI is more than a program. It is a community and a strategy to really change the standards of maternal care. We are seeking to expand and embed these BBI principles, the framework, into more communities and also in healthcare settings. By way of developing stronger data tracking and referral systems to measure the national impact of the BBI. Also to provide BBI-specific and doula workforce training and development to expand services from all the way to preconception during perinatal care and also beyond. And then lastly, securing funding, of course, to make sure it's sustainable and that we can institutionalize this holistic maternal care framework nationally. And so really, ultimately, all women deserve wraparound services and holistic care throughout their pregnancy, also throughout their motherhood journey. And so reducing the effects of weathering and improving the social and emotional health of women really contributes to neuro-nurturing in the womb. So CEC, we really do look forward to partnering with the neuro-nurturing community, and we plan to expand and enhance support offerings by including mental health and neuro-nurturing, as it should not be an afterthought. We should be prioritizing emotional wellness, safety, connectivity for both the mothers, doulas, of course, and also the babies to make sure that we're achieving lifelong health, also offering the preconception education, engaging the fathers and also other support persons. We want to make sure we're incorporating all those aspects into the future expansion of the BBI. And so again, BBI is a model for transforming maternal health, but we can't do this alone. So we would love for you to take and join this journey with us as we expand our services and also invest where all birthing people really do deserve dignity, respect, and the quality of care. And so I have to acknowledge our funder. We are deeply grateful for our funder, Elevance Health Foundation, whose investment has made the BBI pilot possible. And I also want to thank the community and our partners in Cleveland, Detroit, Indianapolis, and Atlanta, who actually brought this program to life. And again, CHC really does. We welcome you to collaborate with us so we can integrate it like long-term maternal and child health ecosystem for all communities. And so later in this webinar, you'll hear about Neuro-Nurturing further with Bill Barberg. And yeah, I look forward to connecting with each and every one of you.
Thank you so much, Demetrius. And I'd like to remind people that the reason for our wanting to do this initiative is people don't know, and probably most do, but that the infant and mortality rate, the rate of Black infant and maternal mortality is 3 to 4 times that of white. And this is a major reason why we wanted to do this initiative. But we do have some questions. One was, how was the BBI adapted to meet the unique needs of each community? And then also, is this a fit for communities where the mothers are nearly all white and Hispanic? So you can answer them together or you can take them separately.
So I touched on this a little bit about the time that we spent in each of the communities. We spent about a week in each community doing those listening sessions and focus groups to understand those needs. And what we noticed is that we took those commonalities across all 3 of the communities at that time, and we were able to say these are the core elements. There were some nuance and optional elements such as journaling, fatherhood support that came out, but that wasn't a core across all 3 communities. And that's how we took that approach. We basically took the qualitative analysis from it and said, let's focus on those commonalities across those 3 communities to develop this framework. And your second question was, is BBI...
Is it applicable to communities that are white and Hispanic?
Truthfully, when you're able to improve health outcomes for Black communities, I truthfully think you can improve outcomes across all communities. We are definitely fluid, and the framework is flexible to meet other community needs. And that is definitely the direction that CC is heading, so that we can serve all mamas, because we all need support. In the US, we don't have the best support when it comes to birthing. We all deserve that care. So I would say, yes, it's a great fit. And if you want to contact me, feel free. We can have a chat about it. And again, we're open to adapting to make sure those elements and those core elements are still applicable to your community. And we make whatever adjustments that the community desires.
That's great. Because you've worked with literally scores of community-based organizations to bring this program to those 3 cities, and we would love to expand it into many other cities. So thank you so much again for this. And to really reiterate the importance of taking the Black Birthing Initiative beyond surviving to thriving, we're going to share a couple of videos.
If I can get this message to the world, I will be so satisfied. People may be surprised or even shocked to learn that our brain development and decision-making patterns are shaped by the first few years of our life experiences. And, you know, when I first started talking to you 30 years ago, we were doing a program called 0 to 6, what happens in those 0 to 6 years. What I have since learned from our discussions is that it's not even, it is 0 to 6, but those first 2 months, which makes sense because anybody who has ever had a baby, been around a baby, knows anything about babies knows in those first couple of months, that baby is just taking in everything. They're like a sponge.
Exactly.
And you're saying in this book that if in the first 2 months, go ahead, explain it.
All right. So
this is it. This is the bing, bing, bing moment. Attention, everyone.
All right. So first of all, I think, you know, there's a lot of work that's shown that adverse experiences or traumatic experiences during development change your biology and make you at increased risk for heart disease, you know, mental health problems, substance abuse, all kinds of bad things. But if you actually start to look at when those adverse experiences take place, it turns out that the most important time appears to be this first, you know, the first start in life, the first couple of months. And so when we look at kids who have lots of adversity and few relational supports in the first 2 months of life, and then they get into a healthy environment, after only 2 bad months, they have worse outcomes than kids that have a good 2 months, and then something happens where all kinds of bad things happen, lots of trauma, lots of adversity.
So human communication is very, very fast and complicated. And babies already are in this system by 4 months. They're already so proficient at it. They're such good communicators. I'm Beatrice Beebe. I run a basic research lab in mother-infant face-to-face communication at Columbia. I study nonverbal communication, face-to-face nonverbal communication. And I study how each one responds to the other moment by moment, fraction of second by fraction of second. And the way we study them, we call microanalysis. We like to say that microanalysis is a social microscope. It allows you to see things that you don't know are there, because the face-to-face communication is so fast and subtle, and you might not really catch it in real time. Below real time, there's an underworld of interactions that you can capture with microanalysis. The research method actually allows you to show that this process is bidirectional. Each person is affecting the other person's behavior moment by moment. When I do educational viewings with parents, parents say things to me like, "Oh my goodness, my baby notices every little thing. I can't believe it." I would like people to be able to see that the baby is extraordinarily responsive to all the little tiny movements of the parent. And they might express their response with a little head shift, or a little hand gesture, or a little foot kick, or a little mouth opening. But when you watch these films frame by frame, you see that with every movement of the parent, the baby, it's a dance. And the two of them are in extraordinary communication. It's very fast. Babies are social from birth. There's this wonderful research by Andy Meltzoff showing that babies can imitate expressions at 10 minutes old. So Meltzoff thinks that the babies can figure out from the beginning of life if their own expression is similar to the expression of the parent. So they get the feeling, I'm like you and you're like me, from the very beginning of life. Here's this 10-minute-old baby. Father sticks out his tongue. Now this baby's thinking. Look at him, he's thinking. So early infancy is really a critical developmental period, right? So we used to think that all the babies need is food and diapering and good sleep and management when they're unhappy. But the whole idea of the social connection was really left out, the face-to-face connection. I communicate to the baby that I recognize the distress and that I empathize with it. The infant's emotional development depends on being recognized. The baby needs to be recognized in the positive moments, and he needs to be recognized in his distress moments. So the father, we don't have many examples of the father, but here's a delicious moment of a baby with the father.
Hey, I'm a gummy bear. Hey, gummy bear. Ooh.
In summary, babies talk to us before they have words, and you can learn to understand the baby's nonverbal language. As early as 4 months, the nature of the mother-baby nonverbal language sets a trajectory that predicts development. Thank you.
And wow, what about that? Did that not warm your heart? What warms my heart a lot sometimes is to look at this beautiful book by Deb McNellis, our next speaker. Deb is an early childhood brain specialist. Her company is Brain Insights. She's an author and publisher and international speaker. Her book, The First 60 Days, the most influential days of brain development, is one of my favorites. I give it to many people. She also has this beautiful collection of brain books that are for each stage of development for children 1 through 5 years old. Deb, welcome. Thank you. We're looking forward to hearing from you about the importance of neuro-nurturing. We're going to get a deep dive into brains.
Thanks so much, Carrie. I appreciate it. And I welcome each one of you to this session. We're so glad that you're here and we have the opportunity to share what we care about so deeply. So I'm first going to talk about what neuro-nurturing is. And it basically is an intentional and holistic support of children's developing brains. And that's happening through some of the points that have already been made about nurturing interactions and responsive care. And that provides, through that, it provides what children need most, and especially in those earliest days of life. So neuro-nurturing is based on providing the physical and security needs of children, providing the nurturing that is required, and providing an abundance of play. So I'm going to ask you a quick question here. Do you know approximately what age the highest functioning area of the brain completes development? Some people are aware of this, and others are still quite surprised to learn that the brain doesn't complete development until about the age of 25 to 30 years old. And I want to make an important point about that. That part of the brain, that highest functioning part of the brain, is called the prefrontal cortex. It's right behind our forehead. And as I said, that finishes developing at about 25 to 30 years old. And when it does, it provides us with the executive functioning skills of prioritizing thoughts, It gives us the ability to imagine, to think in the abstract, to delay gratification, anticipate consequences, to plan, to control impulses, to regulate behavior, and to problem solve. These are skills that we want the children in our lives and in our society to have, right? These are important skills to develop. And this part of the brain only gains all those abilities if they've had healthy development throughout their childhood. These are the four major areas of the brain, and the brain develops from the bottom up. So that prefrontal cortex is part of this cortex at the top of the brain, and that's the last to complete development. So it develops from the brainstem to the midbrain to the limbic system to the cortex. But the point is that all of these areas, that's the order they complete development, but all of these areas are developing all along the way. And one very important point is to realize that the earliest days of life are significantly contributing to that cortex and the prefrontal cortex. It's happening during this important time called the fourth trimester. And the fourth trimester is about the first 12 weeks of life. And so what's essential is that we understand and know what is needed during that important fourth trimester, those important early months, and especially those first 2 months, as Dr. Bruce Perry pointed out. So when we know better, we do better. That's the important point, that we need to understand and then provide all those essential experiences, because the brain is experience dependent, and experiences is what's making connections between the 86 billion brain cells that we're born with. And it's happening at the most rapid rate in this early time of life. So the first trimester and the first 3 years are essential and are making those connections at the rapid rate, with that neuroplasticity happening at that time at a rate of about 1 million connections per second. So the time is now. We need to understand this, and we need to provide it now. And repeated experiences, the brain is experience dependent, but those repeated experiences are what's making the connections happen or strengthen those connections that are being made. The brain adapts to whatever environment it is exposed to. So what's ever happening most frequently in that child's life, the brain will adapt to it. It will adapt to negative experiences as readily as it will adapt to positive experiences. So we have to care what those experiences are that we're providing for children. And so this is a slide that depicts a healthy developing brain on the left side, brain in the center there, depicting a child that didn't have the stimulating experiences and interactions that they needed to make the optimal experiences that brain needed. And the brain on the right is one that had many experiences, but they were the adverse experiences, and developed the brain to be overstimulated in the stress response area of the brain. So this is a model that Dr. Bruce Perry developed called the neurosequential model. And what it represents is the ratio that a brain should develop in for healthy development and reaching that ability to have those executive functions. So the ratio should be that the brainstem, the most focused on survival area of the brain, should have the least number of connections and pathways in it. And conversely, the cortex should have the most connections in it. As I was saying, if they have healthy experiences, that cortex will develop those executive functions that I mentioned earlier. But the alternative is, if a child has had developmental trauma in their lives, in their development, the brain develops in just the opposite way. It develops so the survival area of the brain develops out of proportion. This is a child that is dealing with how to handle the stressors, the toxic stress, the trauma, the neglect, all of those developmental trauma experiences, lack of attachment, all of that child's going to be functioning in a survival mode, because that's the portion of the brain that has developed most and the cognition and the social emotional areas of the brain have developed smaller out of proportion due to lack of experiences happening in those areas. So I want you to stop and think for a second. What if neuro-nurturing community ecosystems were created everywhere? The Launching Lifelong Health Report, which is going to be talked about in a bit, recommends that a strategy for improvement of health and overall well-being should start with public awareness campaigns. And another point to be made is that people serving pregnant women are often focused on physical health, but could easily add tools to help new parents with neuro-nurturing mothers and babies far beyond survival. So this is the neuro-nurturing model that I've created to easily share what research science shows us are those optimal experiences that children need. And we can share them. We need to share them as the Lifelong Health Report recommended. When the science of what babies and young children truly need for lifelong well-being is made simple, shared widely, and is supported, it has the power to transform lives. So creating neuro-nurturing communities is essential. If we want thriving children and strong societies with significant return on investment, we must invest in neuro-nurturing ecosystems. This means offering resources, assistance, and support through systems that are collaborative, accessible, compassionate to new and young families in policy, practice, and everyday presence. And this is just a list of some simple community ecosystems examples. And out of recognizing time, I'm not going to go through this list, but you will be receiving the recording and you can look at these simple ideas to get started thinking about what an ecosystem could provide.
Thank you, Deb. So now we're going to introduce Christina Bethel. Christina Bethel is a professor of public health at Johns Hopkins University. She advances the science of thriving to promote child, family, and community well-being and flourishing. She is the founder of the Child and Adolescent Health Measurement Initiative, the ENACT framework, and something that I love very much that we'll hear more about, the Well Visit Planner. That is a photo of Christina and Sharon Hirsch, who's the president of Positive Childhood Alliance North Carolina, and me back in March.
So I'm going to take a few minutes in setting up Denny, who will share more about what I'm calling one big doable thing, which is the opportunity for us to recognize the degree to which translating the science really is a systems issue and calls upon us to actually practice some of the relational skills we need to with children, with each other as well, in order to really create the integrated systems that we need, and with the goal of flourishing. So we want to look at positive health, not just the absence of the negative, like Bill said, around absence of ACEs, but the promotion of actual well-being. So my aim has always been, I think what ours is collectively here today, to translate the science, because we have so much science now. Over 70 years, really, that I've tracked of concrete science linking early and lifelong health to safe, attuned, nurturing relationships, social adversity, and toxic stress. So we have a lot to build on, but we're still working on translating it. So in 1990, HRSA and the AAP came out with the first Bright Futures Guidelines, which detail out all of the developmental health promotion and supporting parenting and healthy attachment, starting at the first day of life, the first week of life, the first month of life, the second month of life, and all the way through. And then we had Neurons to Neighborhoods, which really brought forward a lot of the neuroscience that we're talking about. And now we have a report that we just came out with. I was a part of that on Launching Lifelong Health. It's continuing the process of the long process, really, of translating the science. So I'm happy we're here today, but we've been up to it for a long time, and there's a lot to build on. What we do know is some of the current focus nationally is on reducing chronic conditions in children. And what we know in our studies is that, first of all, chronic conditions are prominent and prevalent, but they're very related to the relational health factors that children experience. So relational risks like ACEs, or mothers who themselves are not emotionally well or depressed and are very stressed, or anxiety and aggravation in parenting, has a direct shot on development of a child. And so this little graph here can show you that the rate of chronic conditions is over twice as high for children with no social risks at all, no economic or housing or food insecurity issues, but they just have those relational health risks. And that really makes sense when we look at the science. So it's a huge population-based opportunity and need that we have. Also, when we look at flourishing, things like resilience, feeling emotionally connected to your caregiver, a sign of attachment, being able to sort of self-regulate, like you saw in that picture a little bit. We have pretty low rates for our young children who are age 6 months to 5 years old. So the opportunities are huge, and the good news is we know something about how to handle that. And it's especially important because we want children who are ready for school, even just from a population or economic point of view, school readiness, engagement in life, very impacted by all these factors. And it's all of us. So this is just a slide that is saying that once ACEs and relational health risks are at play, the hit on flourishing is the same regardless of household income. So it's an equal opportunity hit, and we know that the prevalence is very high across all income groups. This is really all of us. I'm not going to say a huge amount about the Launching Lifelong Health Report other than to say that it centers the topic that we're talking about today to move from the knowledge that we have about the importance of early life experiences and human development and its ongoing trajectory in terms of how it plays out in disease prevention and so on, and the call that this makes for a comprehensive, family engaged, community integrated approach. And of course, it addresses the need for financing and training and all kinds of incentive systems that can help leverage the systems we have, which we have wonderful systems, but they're not working together or optimally because of some of the gaps. So it really addresses that in depth in order to try to translate what we're talking about here today. And the punchline really is all about primary prevention and making that the centerpiece of what we focus on for the well-being of children and youth. And in this, we know early relational health is the cornerstone. This is actually well supported by the American Academy of Pediatrics, and we've done a number of pieces of research on positive childhood experiences and how powerful family engagement, parent-child connection, and family resilience are to buffering adversity and promoting flourishing and well-being amid that adversity. So it's important that we bring that in, that it's not a doomsday approach. Once you don't have some of these issues, we can do something to really improve it. And alongside ACEs can be positive childhood experiences. And those are really about nurturing experiences. That's the core of positive childhood experiences. So you may not know, but the American Academy of Pediatrics has centered relational health as the solution rather than toxic stress as the problem, noting that even without toxic stress or ACEs, without nurturance and without relational health, we really don't see the kind of health outcomes that we need. So it's really important to center that, and their new policy statement has done that. But also recognizing that to be effective in neuro-nurturing, to be effective in relational health promotion, we need to understand the two-generation approach, what's going on with the family and their capacities to be able to be nurturing to their child. How is the child doing now? Where are they already? And how can I really tailor and personalize approaches to them? And also to do this in a way that looks at the whole child and recognizes that we need other systems to play with us, not just providers or one system like home visiting or child welfare, but we have to work together. And there are a number of challenges to doing that we've been trying to address. But the highest leverage opportunity we have, because it's paid for, it's operationalized, it's something we can move into, are those 15 well child visits that occur from the first day of life all the way through to year 5. And certainly before children get in school, it's important that we focus early. So Bright Futures Guidelines is a roadmap that outlines all of the different topics, and it really does center neuro-nurturing and early relational health. And we need to do this because only 1 in 3 children at this point actually even have developmental screening before they enter school. So we have huge gaps that we can solve. We have a lot of the pieces in place but need to work together. So I want to make sure you know about the engagement and action framework, which is the nickname is One Big Doable Thing. And its focus is on promoting whole child health, which will be reflected in child flourishing, school readiness, as well as family resilience and parent-child connection. And the goals are to make sure we get all children in for the preventive and developmental services that are available to them. in a way that is truly engaging and builds the trust needed to be able to approach topics like nurturance and attachment. We need trust and connection. We need time. So we need tools that can help us to efficiently connect with families, assess personalized needs and goals, and then work together to address the issues that come up. So this outlines a number of approaches featuring mostly this through any door approach, but also a set of tools and toolkits that can be used using existing resources and tools that are available right now and how they could work together. It also lays out an implementation roadmap going from leadership structures at the state and local level to how we can have that public education campaign to create a culture of engagement, a culture of well-being and flourishing, a culture of relational health, and then to really do the hard work of systems change where we get our hands dirty and realize that we're not just going to change by thinking it, but how do we support and give the upfront investment needed that will have a long-term payoff by implementation and scaling. And then finally, what are some of the policy issues that are barriers to being able to act? And many of the policy priorities that we have in the engagement and action framework don't require new legislation. They mostly require collaboration across existing systems, but they are important policy barriers. Okay, so these are all the systems that are in most states and areas, and look at all of them, but right now they're disconnected, sometimes with all the same exact performance measures like getting kids in for well visits, developmental screening, promoting school readiness, but not necessarily together, and none of them are really excelling because of that lack of integration. So that's a lot of what the engagement and action framework focuses on, is this through any door approach that recognizes that with only less than probably a third of kids under 15 months of age coming in for all of the well visits that they're recommended for them, we have the data on that, that we have to meet families wherever they are. That might be in a community-based organization or in home visiting or with doulas or at churches even. And how can we provide tools that can be implemented across a whole range of professionals that are actually the trusted brokers for families so that we can start the process? And that's really what it focuses on. We have one toolkit called the Cycle of Engagement Model, which features an online tool for families that operationalizes Bright Futures in a family-facing tool, produces feedback for them, for whoever's working with them, so that really the focus becomes on engagement and learning and personalization rather than data collection and scoring, and then that the data can be interoperably shared, which is a major barrier. If someone in Head Start engages families, builds that trust, does screening, let's say, starts to get into some of the issues that can promote healthy attachment, even if they can't share that data with the primary care provider or others working with families, they're going to start all over those other providers, and then it just becomes a screening fest, but nothing really happening for the child. So we really have worked to solve that, and the engagement and action framework features those resources. This is just a picture of the Well Visit Planner family-facing tool that can be used for free for anyone here, families, or sponsored by doula or a pediatric provider, so you can learn more here. This is an example of a community health center taking it on their own, and they're up to 12,000 well visit planners, and they've been doing healthy stuff. They're focused on neuro-nurturing, they're focused on early relational health, but weren't able to get the data they needed to understand how to help families and children or get the time they needed. So this has been a game changer for them to use the well visit planner to engage families and so on. So I wanted to make sure you knew about this resource so that it can be used to spark that engagement process and get the information needed in the system. So my bottom line is that we're trying to do child flourishing, which requires early relational health promotion, which requires a whole child and whole systems approach that engages families in every encounter. We have a lot to leverage with the pediatric well visit using a through any door approach, where we leverage shared accountability to drive system integration, and where everyone leads because we all have a role to play in shifting the system.
Thank you so much, Christina. And thank you, Bill Barberg, for editing that wonderful video so that we could zoom in on some of the things Christina was saying. I'm looking for the link to the NASEM report that Christina talked about. Christina, you can come back on camera if you would, because we've got a little time for you and Deb, you as well, to answer some questions. And I've got a question for you, Christina and Deb. integrating neuro-nurturing and your visit planner into electronic medical record systems seems to be a way that we could really get well visit planner and some of this enact going. Is that something that you would like to see done, Christina?
Yeah, okay. So I want to just back up first to say that few children actually come in for the well visits they're supposed to have. And when they do, they're not high quality for reasons that we can solve. And that's really the motivation for why we advanced what I shared to you today, as well as the well visit planner. It's a family facing tool, and electronic medical records are mostly recording data for billing. They don't actually even help care management very well. The practitioners themselves can't even get their aggregate data out to see what's happening with their families. So the well visit planner produces a clinical summary that's like a one-page, all in one place clinical summary that providers do use and can easily put into the record. But for billing purposes and documentation, often they need the data that we're collecting in the well visit planner to be populated. But mostly the screening doesn't happen. When it happens, it's one-off because we don't have this kind of tool. So we have worked from day one in 2008 on the well visit planner to integrate this into the EMR for the business purposes mostly that they have. So the doctor's not spending all the time collecting data that isn't scored and then staying up till midnight to score it and document it for purposes of billing, not for purposes of care management and following up with the patient well. So we do that. It has always been done from the beginning. We have a turbocharger with Epic Ocean. It's really the prioritization of the systems to put a little bit of their IT time on to link to what we have. And then if they're going to do something like a MyChart kind of Epic driven family facing thing, then they have to go much further in redoing the platforms because they're not designed to integrate and create this approach. But we've worked with them from the beginning, many different health EHRs. It needs support. We're doing what most people think costs about $2.5 million with zero funding. And that's because we're just going to go for it. But we have it, we know how to do it, and it's a matter of the systems choosing to partner or go further and build into the EHR system. But that means transforming patient engagement platforms like MyChart. So absolutely, it's key.
Great.
We can be used in the meantime. It's not at all a barrier. You can use it now, get the clinical summary, all the data you need to do clinical care, links to resources for families on the 256 nurturing topics that need to be done and all those things. So it can be used, but the business purposes that the EHR plays is critical to overcome, and we can do that.
We have another question. How can the use of the cycle of engagement and well visit planner start with a large community health center if the state or county has not embraced the ENACT framework? And if anyone has a question for Deb, we can take one more question after this.
Okay, that's awesome. So the way that ENACT and the cycle of engagement is built is to support action by next Tuesday. So Dr. Appel, who runs the People's Community Clinic in Austin, learned about this model and tool while we were on the NASEM Launching Lifelong Health Committee together. I didn't know it, but he just went, signed up, got a URL, started using it the next week. And he's used it, and he's now driving and demonstrating impact so that his local health system and his the Medicaid agency, so he's moving it from the bottom up, but he can take action today. And it's great that they do that, but also a doula system, a home visiting can start the process, have the faith that what they're collecting is validated, standardized, non-proprietary, and it is aligned with the guidelines the health system is supposed to meet, so that they can be respected and share data and be a partner to get kids in with the data already on the table. So it's possible to start right now. And that's what I meant at the very end when I said, no matter who you are, you can start somewhere in the system, even if it's mindsets and education, building the partnerships wherever they are possible, because everyone eventually needs to be connected, learning about, and family advocacy groups, learning about policies that they don't know about. So policy change. So there's a way for everyone. And the tools I mentioned are possible to start using right now. And I can share a lot more about that.
Great. And now if we could introduce Dr. Diana Fishbein. And the wonderful thing, Denny and Christina have worked together for many years, and the Decade of the Child is the outcome of their many years of working together. So Dr. Diana Fishbein is a senior scientist with the Frank Porter Graham Child Development Institute at UNC Chapel Hill. She's a NOVA scholar, and she's the founder and president of the National Prevention Science Coalition. to improve lives. Denny, we're thrilled to have you with us today. Thank you so much for your generosity in being with us.
Okay, I'm so glad I'm here. But I do thank you so much, Carrie and others, CHC, for including me in this really inspirational group of speakers. It's just tremendous to hear about their work. So I'm here with my coalition hat on, the National Prevention Science Coalition to Improve Lives, as Carrie said. It is I founded it 10 years ago. It's become a large professional organization to translate information and knowledge and best practices from prevention science to policymakers. And I'll tell you why. It's because very few people know about it. And it's a tremendously potentially impactful science, but with so few knowing about what prevention science is, it just really doesn't have the impact that it deserves. As you see to the left of this slide is a figure from the 2019 National Academies of Sciences, Medicine, Engineering and Medicine report that shows genres of programs that have been produced by a number of fields that all feed into prevention science. All of these genres contain programs, interventions, policies, practices that have been really well tested across development. And there are so many. And like I said, very few people know about what this knowledge is that's been amassed. And it hasn't really reached policymakers or the public. And when I talk, for example, to policymakers, to Congress, they say, what is prevention science? I never heard of it. Is there a science to prevention? So because they don't know about it, it's really not reflected in our policies, are not informed by that science. And so what we really need to do is emphasize the value of this base of science that it has to improve children's lives. So, but because there's so little knowledge about it in the mainstream, there are very few investments in children's health. They're very low compared to what we know, despite the imperative for current and future generations. And so all of these systems that I have listed here, healthcare, public health education, child welfare, criminal justice, et cetera, that are in part designed to kind of serve children, have been relatively unaffected by the science. And so basically what we know is not being translated to what we do. There is potential for population impacts if we embrace, if we understand, if we broadly implement these strategies that have been well tested, and if we change policies to be consistent with the science. And then if we normalize, and I hope to get to that, if we normalize what we've learned in our daily lives and our interactions with other adults, and especially with our children. And to do that, we need to increase political and public will. And that's very much why I started the coalition 10 years ago. And now what we have, Christy and I are leading a team of people who specialize in child development, prevention, health promotion, economics, advocacy, policy, and so forth to promote an action plan that transforms the ecosystem in which children live. And we're calling this the Decade of the Child. The approach is holistic. It's upstream in that we want to prevent problems rather than only try to mitigate the consequences of those problems. So we want to prevent them before problems develop and become entrenched. And in this initiative, we're especially calling attention to the environmental and the social conditions that give rise to the adversities that stunt children's growth, their academic growth, their neurobiological growth, their behavioral growth, emotional, social, all of that. And what I feel is just so important, because I'm not just all about interventions. Interventions aren't going to change the world. They're not going to have, a single intervention isn't going to have population level effects. But instead, what we need is a whole complement, a whole constellation of interventions, programs, and practices that are supported by policies, because policies have the potential to scaffold that change that communities need in order to holistically focus on children's health. And by scaffolding it, it means we can sustain those changes over time, and we can influence the public by helping them have access to that knowledge in an accessible framework. Then we can achieve population level effects. And it's just important to note that all these conditions that can lead to negative outcomes are fundamentally alterable: individual, interpersonal, institutional, community, public policy. They're alterable, and we know how. We know how to prevent adverse childhood experiences. And as per what Christy was presenting, we know how to strengthen positive childhood experiences. And I should not neglect to say that all of the speakers before me, Deb and others, have all indicated strengthening positive childhood experiences are absolutely essential, and that Bruce Perry really emphasized. So I'm going to say the same thing that Chrissy just said. It's time to act. We need to focus on the factors that influence child development and then can reduce risk for all of these potential problems, which are currently at unprecedented levels. So our Decade of the Child initiative is intended as a giant step in that direction. You'll see these two reports here. The one in the middle is the 2019 National Academies report that was excellent. And then the Launching Lifetime Health that Christy has already presented on. Together, they provide us with a roadmap and other materials. Obviously, there's decades of work that has been done here that we have in hand. We have a roadmap in hand in the form of a national policy agenda, and so that we can effectively prevent these harms and increase exposure and the prevalence of positive experiences. So our Decade of the Child initiative is all about promoting whole child health and well-being, and we're organizing an effort across a number of sectors: parents, community stakeholders, and organizations and coalitions, foundation heads, and agency officials to do the following things. We want to urge Congress, agencies, foundations, and other funding entities to invest in an actionable, applied research agenda. What do we still not know about how to embed these practices and make them part of our zeitgeist in our communities? We also are advocating with policymakers to prioritize, asking them to prioritize their agendas, to focus on whole child health and what that means. So actually incorporating this as a very important priority for policymakers. We're also asking them to engage communities and local governments in embracing the principles of prevention and health promotion by providing those services and those supports and investing in families so that it can all happen. And I see this tiered, right? The policies can help entrench, it can help to sustain what can be done at the community level, and the communities are telling government what they need. It has to be community driven. So we're engaging in a lot of community work. And then we're also organizing a public education campaign. So we want to increase public awareness. We want them to clamor for this. So we're asking Congress, these are just some selected policies. We're asking Congress to evaluate their own policy priorities, as I said, and identify opportunities in their own agendas to invest in a focused child-first kind of policy agenda. We're also asking them to advocate with their colleagues, their congressional colleagues, so we can seed it throughout Congress. We're asking them to explicitly state a child-focused policy concern or a set of concerns on their own websites and their other informational materials that goes out to their constituents. And we want them to actively inform their constituents of these issues and their own commitment to tackling them in a way that fits within their own policy portfolio. And I'll just stress that the United States is the only country in developed nations that does not support parents. And so this needs to be a number one concern in this country. Now, it's not just about legislation, though, and I want to point that out because it's also about policies at the agency level, federal, state, and local levels, like health and human services agencies, school districts, organizations. We all have policies. Universities have policies. Every component We want to get to every component of the ecosystem that influences children so it can be better transformed to serve our children. And to get there, it's important for the public to understand this imperative, as I just said. So in addition, we're providing written materials. This is a flyer. We probably should update it. Things are happening quickly. But in addition to a lot of written materials and op-eds and commentaries and fact sheets and so forth, we're also collecting success stories about how this kind of approach has improved whole child health and well-being, and about ways in which any present policies can or have harmed children. So please send those stories to us. Please send them to me, and we will get back to you and use them if you will allow us to. It can be anonymized. So I'm promoting this concept of it. Children's culture of prevention. We want to normalize nurturing practices to make them a normal part of life and strategies that we engage in with each other, with our children, so that they are foundational, so that they exist from birth to death, and that these kernels of practices that we've learned that improve the interactions with children, improves their health, that we do them daily, that they're part of our, well, like what Christy said, they're in the well water. Okay. And so I didn't think I was going to get to these slides, and I'm not, but they will be in the slide set that is provided later. And you can peruse them at your leisure, but just some ways of drivers of normalization, a fabulous book, and then endorsing this. You probably don't have a chance to take a picture now, but when you get a chance, go to the website and you will find more information about our Decade of the Child and be a mission promoter. Thank you so much, Carrie, for your patience with me.
Oh, thank you so much, Dr. Fishbein, Denny. We appreciate you, and National Prevention Science Coalition is a nonprofit partner of creating healthier communities. And so we intersect in so many different ways, but we're deeply grateful for that. To have you with us. And so now it is my pleasure to introduce Bill Barber. Bill and I have partnered on many webinars through the years. He is the Population Health Strategy Implementation Consultant and the president of Insight Formation. He is a recognized leader in large-scale collective action and system change. He finds ways to solve wicked problems. Because Josh Zawadi is not with us today, Bill is also going to share Josh's slides. So thank you so much, Bill. Welcome, and deeply grateful to you for so many parts of all of this.
Okay, thank you very much. So in this section of the webinar, we're going to be shifting into how do we move from the wonderful research and all of the recommendations to the practices and that can bring the population level outcomes. And a lot of that involves how do we organize and align efforts for large-scale transformation. In the Launching Lifelong Health Report, there's many recommendations, but recommendation 1-1, the first one, talks about the importance of developing a framework for promoting infant, child, and adolescent health, because there's so many different elements, and an enduring implementation plan, because too often these reports don't lead to the kind of changes that they would have hoped for. And so I want to introduce just a few concepts. One is a theory of transformation in the form of a strategy map. Many of you may have experience with logic models and theories of change that are designed for more isolated interventions. But the theory of transformation and the related practices are about how do you bring about big change that take a long time and have a lot of different components. And we think it's very important to include neuro-nurturing in the efforts to improve maternal and child health and to launch lifelong health. Now, people often say, well, is this an evidence-based practice? And it's not the kind of intervention that you can do a simple control group and do a 2-year study and see if it works, because it's an approach to how you bring about large-scale change. But there are multiple peer-reviewed journal articles, such as this one on leading social transformations, creating public value and advancing the common good, that have been co-authored by the leading people in the field, like evaluation, kind of the grandfather of evaluation, Michael Quinn Patton, and others, that are really recommending these techniques and tools, which we're going to give you just a little sample of. So a strategy map, or a theory of transformation for neuro-nurturing, has improving maternal and child health up here in the upper left corner. And a lot of that has traditionally focused on supporting mothers. But we're expanding this to say we really need to focus on the baby's neurodevelopment, their attachment, which leads to self-regulation, executive functions, language and literacy, and school readiness. As we've said, it starts with increasing public understanding so there can be broad engagement of these things. And then some of the kinds of things that the Black Birthing Initiative emphasized, helping with the mental well-being and supports of the mothers, using doulas, enhancing home visiting programs, and other elements. We also see objectives for enhancing the team. And one of the biggest opportunities is to increase the role of fathers in supporting neuro-nurturing in their babies. There's also optimizing the well child visits, which Christina talked about in her session with the well visit planner and the ENACT framework. And these pluses mean there's a whole nother level of detail behind them. There's several ways to mobilize the community to really support neuro-nurturing. For example, create networks of neuro-nurturing community baby showers, engaging volunteers in long-term relationships with the babies and the new parents, and increasing neuro-nurturing training and practices among early education and care providers. So this framework helps organize many different pieces, and the related practices help you measure and monitor and have action plans for many different organizations working on these. And one where Josh Liston Zawadi has really been a pioneer, it combines these areas, and that's the idea of dad doulas. Josh couldn't make it at the last minute, but we do have recordings because he and I just did an online conference presentation on Tuesday, and we're going to edit that down and you'll get to hear a little more detail in that. But the basic story is when his wife became pregnant and she had a doula, he saw all the attention and support she was getting, and he said, I need that kind of support too, both for myself and to know how to help my wife as she's going to be having this baby. And he was actually working for the Children's Hospital of Milwaukee. He was working as a community health worker. And so he had some background. And they said, well, you need to create this. So that led to the idea of Dad Doula University. And many of you are familiar with what birth doulas do in working with the mother. But the Dad Doula has similar, but it's helping the father in their own healing and growth and journey, as well as how the father can really play an active role in the birthing process. So he started it in 2020. He left the Children's Hospital of Milwaukee. He offered it as an online program serving about 100 people as he was kind of refining it, and then began launching it as an 8-hour program, either over 2 4-hour sessions or 4 2-hour sessions in Milwaukee, funded by grants, so the fathers don't need to pay. And the vast majority of his people both come by referrals and then refer others. So it's really taking off, and he just got an award last night. So some of the key topics that they cover are things such as fathers being very important caregivers, not just protectors and providers. The importance of nurturing and loving affirmations for both the mother and the baby. A lot of teaching about how do you really bond with that baby, the skin-to-skin connections, the face-to-face things we saw in the videos that Beatrice Beebe shared. Significant training to overcome misperceptions and the fact that many fathers lack good role models, so there's a vacuum to fill in teaching them to be nurturing fathers. There's also elements of helping fathers heal from their own experiences so we can break the negative chains and build skills to meet their baby's needs. So this whole program is very much targeted for fathers and has been really well received. To date, Josh has reached over 500 fathers, and he's happy to say they've had 100% healthy births, 100% healthy mothers as they launch infants with strong attachment and nurturing. He's also an ordained minister, and they've married about 30% of the fathers to the mothers of their child. So he's building families and building communities with this growing ecosystem of fatherhood supports. And now the exciting thing is he's really working on scaling up Dad Doula University to be able to train fatherhood support specialists in different communities who can work with these fathers. He's almost done with taking his core training material and putting it into an e-learning program so there can be a mix of the e-learning and in-person in communities across the country. So this is one of the things that we're excited to bring to you and to integrate as part of this larger strategy. The last thing I'm going to show is just a quick glimpse of a free resource, which I'll put in the chat. It's the ACEs and Resilience Resource Commons for Communities. It's built on the same platform as Wikipedia, and we're putting in a template of the strategy map. And I'm just going to zoom in on this increasing fathers supporting neuro-nurturing. And here we can see expand training for fatherhood doulas, expand or improve outreach to fathers before the baby is born, develop cultural supports for the father's role in neuro-nurturing. When we click on this, it takes us to more detail, like you would find in Wikipedia. Things like what are some of the resources that are available for training fathers? And our goal is to get more and more of these in Spanish. We don't have many yet, but that's where we're trying to move to. So in all of this, we want communities to be able to really build neuro-nurturing ecosystems without needing to reinvent the wheel. Sharing promising practices, sharing measures, all the things that are important for supporting a theory of transformation. And we have other webinars, and I'm going to put some links into the chat where we go through some of these secret sauce ingredients that can be ideal for helping fathers who often feel unprepared and ill-equipped. There's many things that can be done. And I'll just make a last shout out here for in St. Paul, there's going to be a live Black Men Healing Conference focusing on Black fathers. Joshua and I are expecting that we'll be presenting there as well. So I'm going to pass it back to Carrie and hope that was helpful.
Bill, thank you so much for what you shared, which is mission critical and so important and vital, and it has worked in so many communities. I've seen what Bill has done in communities across the country and Canada, and it's remarkable what happens when we build these strategy maps and start weaving things together. Thank you for sharing double duty and sharing Josh's slides as well. So yeah, what we're really talking about now is a vision for the future. And Demetrius said this the other day, and it was so true. When we neuro-nurture the mother, we neuro-nurture the mind of the next generation. Early investment in a mother's mental and emotional health, and the father's, I'll ad-lib that, Demetrius, builds the neurological and relational foundation for the family and the baby to thrive. Paraphrase. So why now? Why are we talking about the power of neuro-nurturing in early life? As you've heard, we want to help build trust and curiosity and connection, as opposed to without neuro-nurturing and when there's inconsistent nurture and toxic stress, fear, isolation, and relational challenges. We want to do this for both infants and caregivers. CHC plays a role in the natural progression of all of this, as do the speakers. To add, on the Decade of the Child, Christina's Child and Adolescent Health Measurement Initiative co-authored the Decade of the Child with National Prevention Science Coalition. We're used to working together. We're now wanting to launch this neuro-nurturing collaborative, building on the successful model of our Black Birthing Initiative with these upstream maternal-child health work. PACES Connection, many of you know about PACES Connection, I'll put the link in the chat, has examples of this cross-sector work in about 400 geographic communities around the country. So this is a call to all sectors, healthcare, education, faith, family services, to co-invest in our most vulnerable and valuable assets. Corporate partners can play a role too. I'll put in the chat in a minute the Family Forward Workplaces Initiative out of North Carolina. It matters because prevention, as Denny stressed, prevention is power, y'all. Sad mamas have sad babies who grow up to be children with challenges and then adults with challenges. We know if a child can't read by third grade, the likelihood that he or she will have challenges with incarceration increases greatly. So the links to low literacy, poor focus, incarceration, underemployability, relationship challenges are huge. The lack of positive childhood experiences perpetuate ACEs, and the addiction and abuse and neglect that often go with them. Neuro-nurturing is a positive childhood experience, y'all. Positive childhood experiences are known preventives for adult mental health challenges. So we've got here an efficient upstream prevention technique, collaborative, to help with lifelong health. We're going to be dealing with Alzheimer's and dementia and aging in a healthy manner in some upcoming webinars. If we had started neuro-nurturing 50 or 60 or 70 years ago, we might be in a different place right now. So we're offering hope across the lifespan that healing and growth can happen at any age, but especially in this 0 to 3 window and that important 4th trimester. We have a great start here with the Black Birthing Initiative. We've got structure, we've got framework, we've got evidence that it works. We know we can build collaboratives and coalitions. We know we can do collective impact work. So now we can take this model and replicate it and scale it. There are many ways that you can start weaving neuro-nurturing into your organization. Deb has a great slide that we'll share that mentions some. Here are just a few. If you're a healthcare worker, you can find out more about the Well Visit Planner on NACT and ask your team about integrating this in. If you're a community organizer, you can talk about the Daddy Doula program. If you're a birth worker, you can get in touch with Demetrius about the Black Birthing Initiative in your area. If you are with a resiliency task force, you could come together like my city, Wilmington, did last Friday and have a community baby shower, like Deb mentioned. There are many, many ways that you can enter into this neuro-nurturing collaborative. The key is to connect with us because we really want to track the activities. So the key is to start somewhere. A final few words about CHC. If you're part of CHC, we would love that as a nonprofit partner. We can help you do more. If we can help your nonprofit in raising more funds, your nonprofit can do more as an involved member of a neuro-nurturing collaborative. Application services, donor data, marketing support, grant writing support. Doing this collaborative is going to take some grant writing. We've got that capability. So a vision for the future that pregnancy and early parenthood are as much a neurological journey as they are a physical one. Supporting the mother's mind is not optional. It's essential. Her wellness becomes her baby's wellness and a blueprint for safety, connection, and lifelong resilience. So what we have upcoming on June the 26th, understanding the workplace giving cycle from pledge to payment. And then in July, our AARP series, the role of the community in shaping healthy aging. So again, we thank you for being with us. Your questions will be answered in the email. And thank you again to Bill, to Denny, to Christina, to Deb, to Demetrius, and especially Tyler for handling all of our tech. Thank you all so much. Please reach out to me with questions, csip@chdimpact.org. Thank you again.